Good morning, everyone. I am Christine Andrews Stobart, and I am the Knowledge Translation and Training and Capacity Development Lead at SCPOR. That's the Saskatchewan Centre for Patient-Oriented Research. It's terrific to have everyone join us this morning as we celebrate the research three teams will be presenting this morning. On a housekeeping note, please note all engagement tools are found on the right-hand side of your screen. You can use the chat feature to submit questions, and to engage with other attendees, use the chat function. If you'd like to participate in polls, if there's any polls upcoming, please click the poll feature of the platform. I'd also like to remind everyone that we do have a code of conduct for the participation for all the participants of the 2021 Research Showcase. And Research Showcase is dedicated to providing a harassment-free conference experience for everyone. And we ask you only submit questions and comments relating to the presentation topic. So on that note, I'm going to turn over, I'm going to welcome Michaela Hagel. It's my pleasure to introduce her. She'll be presenting her research on promoting healthy eating with urban Indigenous seniors living in Regina, Saskatchewan. She holds a Bachelor of Health Sciences, Health Studies from the University of Regina with a focus on Indigenous health research and the natural sciences. As an ally, Michaela's research interests are to meaningfully contribute to the decolonization of the Canadian healthcare system with leadership and guidance from Indigenous community members. Welcome, Michaela, and over to you.
Awesome. Thank you. Let's grab that. Okay, there we go. Hello again. My name is Michaela, and thank you for joining and listening about this important work. Before I get started, I would first like to take the opportunity to acknowledge that the land on which I'm presenting on is Treaty 4 territory and the traditional territory of the Cree, Dene, Nakota, Lakota, Dakota, Saulteaux, and the homeland of the Métis Nation. So food insecurity is a major concern raised by Indigenous communities across Canada and on a global scale. The First Nations Regional Health Survey reported in 2018 that nearly half First Nation households were categorized as food secure, while the remaining half were either moderately or severely food insecure. Food insecurity can be described as insufficient or inconsistent access to nutritious foods that meet the dietary needs in a socially accepted manner. And achieving food security relates to a person's access to physical, social, or economic resources related to obtaining that food. It is commonly accepted that food insecurity is associated with lower diet quality and can lead to both physical and mental health ailments. But going beyond the physical and mental importance of accessing food, it is also important to acknowledge the key cultural, spiritual, and economic value that traditional foods hold for Indigenous peoples. The global pandemic has impacted all dimensions of food security, from food availability, accessibility, utilization, and stability. So looking ahead, Canada's Food Price Report for 2021 describes that consumers can expect an increase of up to 5% in food prices. So realizing this and the overrepresentation of food insecurity experienced by Indigenous peoples and how the pandemic has impacted access to food brings forward the following questions. What are meaningful steps or interventions that can be taken to improve current access to healthy and affordable foods for Indigenous communities? And how can this support be sustained long-term, even after the pandemic? So a promising way to approach these questions as an ally is to conduct ethically engaged and community-led research that seeks to empower sustainable, culturally relevant, and community-determined solutions. Research should be at the service of Indigenous communities to ensure its findings are sustainable, culturally appropriate, and ultimately build capacity. So through Morningstar Lodge's community relations, the need and concern to address food insecurity for Indigenous older adults during the pandemic was brought to our attention. Guided by Indigenous research methodologies, all projects at MSL are developed, conducted, and disseminated at the direction and service of community. As a lab, we strive to promote supportive environments through creating healthy, reciprocal, and respectful relationships. So to mitigate this community-identified research priority, Morningstar Lodge formed a partnership and research agreement with Zagame Anishinaabe First Nation for the provision of good food boxes. 55 co-researchers were provided with good food boxes for a total of 7 deliveries that were delivered bi-weekly that included fresh produce, meat, and legumes. In addition to fresh foods, the program provided a handout with each delivery explaining the food contents, nutritional facts, healthy recipes to make with the ingredients provided, and culturally relevant information. So the good food box contents were curated and packaged by Mike's Independent Grocer, and funding for this project was provided by the New Horizons for Seniors program. The 55 packages were delivered bi-weekly by Morningstar Lodge's staff members and family volunteers for a total of 7 deliveries. So getting into the specifics of what was included in the good food boxes, on top you can see this is an example of an actual food box delivery. So it included a plethora of fresh and frozen produce, legumes, and various meats. We paired each delivery with a printed pamphlet that was unique to each delivery. So for this delivery specifically, the pamphlet included, what's in the box, naming all the ingredients, how to properly store the meat, so fresh and frozen, and how to store the leftovers. We provided nutritional facts specific to the good food box contents, and also provided multiple healthy recipes specific to the ingredients. So they knew how to use the ingredients and how to cook good meals. So as this was an example of our last actual delivery, we also provided community food supports to supplement the good food box after the program had ended. So co-researchers knew where to access more supports if they needed it. So community also expressed the need for educational material relating to COVID and staying safe. So along with that printed pamphlet, we provided additional handouts on protecting our home fires fact sheets, which was a campaign run by Morningstar Lodge on COVID. And we also provided sheets like 19 things to do at home, which provided information on supporting wellness and also navigating grief in a culturally appropriate manner. So for data collection and analysis, the Zagame community contact person, along with Chief Lynn Akus, guided the implementation of the project and led the community recruitment strategy. We were able to recruit 55 people for the program, and inclusion criteria where they were members of Zagame living in Regina and were 55 years or older. So for data collection, co-researchers were asked to answer 2 confidential questionnaires via telephone, one at the beginning and one at the end of the 14-week period. The questionnaires assisted in examining if the project had achieved its intended results to support healthy eating, and determined whether or not access to healthy foods through the good food boxes contributed to healthy changes in their diet and overall well-being. So the retrieved data was analyzed using NACPA. The proper spelling of NACPA is on the last bullet point. I unfortunately cannot pronounce it, but the Cree translation translates to medicines, healings, stories picked, sorted, and stored. And NACPA is an Indigenous qualitative data analysis method developed by Morningstar Lodge. So this method innovatively bridges community, individual, and research knowledges to establish a collective and consensual agreement of how to sort the retrieved data. So this is done by including community members during the actual analysis and sorting of the data. And it relates to why research participants in this project are referred to as co-researchers, as they were actively engaged in all stages of the research and were equally engaged as joint contributors and investigators, and analysis is no exception. So the findings and the themes drawn from the surveys that were done were all of the analysis was done with community to make community determined solutions. So for the findings, the first survey was collected prior to the Good Food Box deliveries to gain an understanding of co-researchers' current knowledge on what healthy eating means, the benefits of eating nutritious foods, understanding barriers to accessing food, and how COVID has impacted their current eating habits. So what did we learn from this first survey? We learned that co-researchers expressed the current barriers they experience to accessing healthy foods, how kinship systems influence food choices, like providing for a family. Sometimes people had to sacrifice their own meals to provide for their kids. And we also learned about the health impacts from current eating habits and how COVID has impacted all of that. We also learned that it was really important to co-researchers to learn more about the traditional knowledges pertaining to food and medicines. So the second survey was administered after all of the deliveries were made and found that co-researchers felt that the Good Food Box generally improved food quality and consumption, and made it more accessible to obtain that healthy food and alleviated financial barriers. We also received valuable feedback on where to make improvements for the Good Food Box program in the future. So overall, co-researchers gave positive feedback about the program and expressed their sincere interest in participating in similar projects in the future. On the slide at the top, I have included a co-researcher testimonial from the project, and it basically sums up what the majority of our feedback looked like for this project. So as a result of the Good Food Box initiative, Morningstar Lodge has supported 2 Indigenous communities to apply for their own successful New Horizons for Seniors grant to continue to support accessing nutritious food and improve food security for their communities. The awarded funding will be held by community members themselves to make their Good Food Box program tailored to their specific needs. As we continue the relationship with partnering communities, Morningstar Lodge will continue to provide mentorship and support. Not only was Morningstar Lodge able to support healthy eating and alleviate barriers to accessing healthy foods in current times of the pandemic, but we were able to make an impact for sustaining the support long-term with communities applying for their own grants. Achieving food security cannot solely be supported by short-term solutions like the provision of the Good Food Box program, but with community-based research that prioritizes mentorship and building capacity, the community is empowered to determine sustainable and lasting solutions. So moving forward, we need to continue to emphasize research that is at the service to Indigenous communities and supports research, Indigenous communities and supports research that is led by the community themselves. In the few short years, I have had the opportunity to do research with community. I have learned that community already has the answer. My role as a researcher is to serve and to take direction from community and listening to co-researcher feedback and their interest to continue the program in the future demonstrated the need for further funding to support community-led solutions to improving food security for Indigenous peoples. Thank you.
Thank you so much, Michaela. We have an opportunity for a few questions. We have a few minutes to chat. If anybody has questions, please write them in the chat box for this session. If not, I have a question or two just to get us started. I do believe people could also put their hands up, and we might be able to answer those if you can't get to the chat box as well. But Michaela, what I'm really interested in is, was there any desire, or did you receive any feedback on actually including traditional food or country food in the boxes? And is that a reality, or is that something that's being considered as an option in the future?
That's definitely feedback we received from the second survey, was to include more traditional foods and more teachings on those traditional foods. So for example, someone had mentioned that we should talk about Three Sisters, and it's a traditional method of planting and gardening, where you plant three vegetables, three foods in your garden that are all kind of work symbiotically and work to support each other, like the foods between each other in the garden. So that was definitely a priority, and definitely provide more teachings on traditional foods. So I think that's something that in this next phase, in this next Good Food Box program, it will be a priority for sure.
Yeah, thanks. I was just wondering, because I was thinking, in some ways you could foster a whole sort of reciprocity if people in more rural and remote communities were able to provide traditional and country foods, right? Mm-hmm. Not that I'm even suggesting a business model there, but you'd think that there would be that kind of reciprocity might be advantageous to those in urban settings and those in rural settings. So
absolutely.
Yeah, and it's of course this is just the start of something really good, it sounds like, but yeah, I think there is probably lots of opportunities to expand this on a big scale. Do we have again, if anybody has any questions, you're more than welcome to put those in the chat box. I just want to also say, Michaela, one of the other things that is a takeaway for me from this presentation is this whole idea of, I believe you call it NACPA.
Yeah. Yep.
And that whole idea of Indigenous qualitative data analysis, is there any more information, or is there any way that people can find out more about that? I don't know if it's software or a program, or if it's just if it's something that is, even if there's an article on, or if it's written up, because I think that would be that. I mean, it's new to me, and I think that could have real value to others. So if you could just share a little bit more on that.
For sure. So actually, if you check out our website, so the indigenoushealthlab.com, we have kind of more information on training regarding NACPA, but we also have an article that was published in 2019, kind of outlining the process. But kind of, to explain it in short, it's an Indigenous qualitative data analysis method, and what that means is that people are able to share their thoughts regarding the research in a culturally appropriate and relevant manner. And even the sorting process is culturally appropriate, because it's not just one person deciding how to organize or how to understand or how to make sense of the data that was retrieved. The NACPA process ensures that community members are engaged even through the data analysis. So that means that they're finding their own themes, they're finding their own priorities from the research, and making sense of the research themselves. And that really respects the notion of Indigenous data sovereignty principles like OCAP and the care and fair principles as well. So it really puts research back in the hands of Indigenous communities. As in academia, the tendency has been to research on Indigenous communities rather than with Indigenous communities. And this NACPA is just really one step that researchers can take to engage in ethical research that, that is culturally relevant and ethical.
Thanks a lot, Michaela. I see that somebody is actually, I think Carrie has put in the chat box, both, I think, a journal article, and also looks like it's probably also a website of some sort, and we appreciate that because I think, yeah, that's a great takeaway. Thank you again, Michaela. I think we'll move on to our second presenter. That is Dr. Mamata Pandy, and she'll be presenting on the lessons learned from the Indigenous Birth Support Worker Program. She is a research scientist at the Saskatchewan Health Authority in Regina, and she employs innovative research techniques to identify evidence-based strategies that can improve the quality of care delivered to patients in health research. And she's developed a strong research partnership with several organizations serving newcomers, and she engages them fully in her projects. I'm pleased to share that Dr. Pandy, I believe, also has two patient partners joining her today. I believe that is Angela Tompkins and Nicole Maxek is, I hope I've got that right. And I just want to share that Angela Tompkins is from Pound Maker Cree Nation and has been an Indigenous birth support worker for 2 years, and says she absolutely loves her job. And she's a mother of 2 daughters and happily married, and is really encouraging her daughters in ceremony and creating traditional Indigenous styles of jewelry with healing crystals. And we also have Nicole Maxek with us, who is the operational manager with maternal services, and she's been co-managing the maternal care center for 3 years and is the lead manager for the Indigenous birth support workers at the Jim Pattison Children's Hospital. And again, before I turn it over to you, Dr. Pandy, I'll just remind everyone to please remember to submit your questions in that chat feature on the platform. And over to you.
Thank you. I'm going to actually start it off today. I just wanted to thank everyone for all the wonderful presentations thus far, and I'm very thankful to be a part of this day. I also want to acknowledge that we're gathering on Treaty 6 territory and homeland of the Métis. Recognizing this history is important to our future and our efforts to close the gap in healthcare outcomes between Indigenous and non-Indigenous people. I pay my respects to the traditional caretakers of this land. As well, before starting, I just want to give a little bit of background of where the Indigenous birth support worker has come from. In 2017, an external review was commissioned to better understand Indigenous women's experience with the tubal ligation. The steering committee consisted of elders, cultural advisors, knowledge keepers, women from our community, physicians, and staff. A recommendation from this committee was to develop an Indigenous birth support worker program. Saskatoon is our demonstration project of the Indigenous birth support worker. The maternal care center that's located within Jim Pattison's Children's Hospital, it offers First Nation, Métis, and Inuit women the support of the Indigenous birth support worker as part of our commitment to truth and reconciliation and calls to action. This free program is an important step to reestablishing trust. We wanted to evaluate this program today, or to present our evaluation of the program to see if it's meeting the needs of First Nation, Métis, and Inuit women coming into Jim Pattison's Children's Hospital.
Thank you, Nicole. I'm Mamada Pandy, joining from Regina, Treaty 4 area, and I value my partnerships with First Nation communities and people who support me in carrying out many of the projects that I'm engaged in. I will be presenting the results of the program evaluation. So taking on a mixed method approach, we collected quantitative and qualitative data. Within the time frame of December 2019 to January 2021, 1,023 clients received services from this program. Majority of the clients arrived from La Ronge and Battleford area, and 49% clients were recruited by the Indigenous birth support workers. Postpartum support, visitation on prenatal unit, and postpartum visitation were the most important or most frequently offered services through this program. 34 clinicians from a variety of clinical specialty completed healthcare provider survey, and 41% agreed that they were aware of the program referral process and they felt comfortable expressing their views to the Indigenous birth support workers. 44% agreed that the program was well received and can be expanded to other centers. 53% healthcare providers agreed that Indigenous birth strategies should be integrated with best practices for clients who prepare it. This quote from a clinician highlights the impact the program is having on Indigenous women who might have experienced loss or are alone in the healthcare setting, traveling from their home communities. The perspectives of the Indigenous birth support workers were explored through focus groups, and 10 individual interviews were carried out with clients. The thematic analysis indicated that Indigenous women required assistance trying to access healthcare services within the hospital setting and also needed assistance managing pain. They also required support connecting with various programs outside the hospital in the community, like child services, social services, etc. Currently, the Indigenous birth support worker program is offering a variety of services. Cultural teachings, wisdom, and knowledge provided by this program is highly appreciated by the clients who receive it. Indigenous birth support workers provide companionship, empathetic listening, and advocate for Indigenous women to gain access to timely healthcare services within the hospital setting. This quote from one of our clients really highlights the importance of having access to cultural and traditional teachings while they're receiving care in the hospital setting and the healing effect that it has on many who receive it. Clients did report suboptimal experiences with healthcare services. At times, care can become non-compassionate and judgmental. There is need for collaboration between clients and clinicians to achieve better pain management. Some clients did report experiencing positive experiences during their hospital stay. It is important to look at the communication styles between Indigenous birth support workers and the clinicians, which was primarily good as they were able to communicate freely to help clients access care. Clients had positive comments about the communication they had with Indigenous birth support workers. However, there is room for improvement in communication between clients and clinicians in the hospital setting. Information about the Indigenous birth support worker program and the scope of services of the Indigenous birth support workers can be promoted among clients and healthcare providers such that there is improved program uptake. There is need to provide continued cultural and doula training to the Indigenous birth support workers to ensure that the care that they are providing is high quality. Through prenatal classes that can be provided to the various First Nation communities across the province, it is possible to develop and strengthen relationship with community healthcare workers such that there is smooth delivery of care or handover of care to and from communities. And I would like to turn it over to Angela.
Hello, my name is Angela Tompkins. I'm one of the first birth support workers that did the training and everything. I'd just like to talk a little bit about the moss bag and the belly button pouch. So this is our teaching moss bag. In any moss bag teachings, I always have a gentle reminder of that the Creator gifted our babies to us. They're on loan. The moss bag itself is also another gift that the Creator gave us Indigenous people. It's used for child rearing. It's used to heighten the baby's senses while they're in there, to calm babies. The moss bag represents the mother's womb, And every part of this tool is representation of the woman's body, her pregnancy, and our people's creation stories. So there's a lot of meaning in every little aspect of this moss bag. When a moss bag is used, healing can occur between the mother and child because it's an instant link to our culture and hands-on way of traditional parenting. We all know the intergenerational trauma Indigenous people cope with today and having access to traditional parenting is key. I always encourage parents when wrapping baby to think of the positive and the love that was involved to create their child. The creator made no mistakes, and here she allowed the spirit to come into this realm, to this world. There is nothing more reassuring and beneficial to a human being's mind, body, and spirit when knowing you are meant to be here and you have a purpose. The belly button pouch that we like to gift every family, it looks like this. It's not the actual traditional, but it's the aspect of the belly button, keeping the belly button and returning it back to the land is. In Neheo ways, we call it the Utsi. A lot of First Nations people have this memory or instinctual habit to keep their baby's umbilical cord once it falls off their child and not know why they keep it. The Utsi teaching can differ from family to family and tribe to tribe, so we always inform patients to seek family and our local elder or knowledge keepers if unsure. The act of returning and giving thanks and appreciation for your child to live into adulthood is a beautiful way of living. So when we talk about returning it back to the land, that is a way that the parent can ensure that their child in adulthood lives a good way. So there's like connections to where you put your baby's Utsi. So some people will put it by the water. Some people put it in a clean area in the bush on the trap line. Some people put it in a tree. There's so many different ways, and just returning it back to the land, it just makes everything full circle again with our teachings. And it can help with the next generations to come. So like something as small as the belly button, it has so much significance. It has meanings in our ceremonies, in our medicines when we have altars, everything. Like it's just very important. So I always like to gift everyone a belly button pouch. And as I always say to the patient, it's an act of love from the Indigenous birth support workers. So like, we just want them to know that we love them, we appreciate them for letting us be a part of their stay, their child's delivery, even the teachings themselves. It's always such a beautiful time of my life and my day when I get to do a moss bag teaching, or just to explain the belly button, or hear families say like, oh yeah, I kept my older children's belly buttons, but I didn't know why. And now I'm gonna put them all together. And you know, that's just beautiful and amazing. So I'll leave it at that. Thank you.
Thanks, Angela. You're muted, Annette.
That brings us to the end of the presentation. Here are some references, and we're here for questions.
Thank you so much, Dr. Pandy and Angela and Nicole. Really, really interesting work. And yeah, I was fascinated by, I mean, all the ceremony that is really, really interesting to hear about. On that note, I'm just wondering, you talked about this being a demonstration project, right? Where do you go from here? Like, is there any indication that this might move into other locations? And I was thinking, you know, there's a lot of hospitals in rural communities that deliver a lot of babies, and I'm wondering if there's a possibility this program might be able to move into those communities where I'm sure it'd be well received as well.
Yeah, Christine, that's a great question. And that was part of the reason behind our review of the program, to see if we're meeting the needs of the clients and areas that we need to improve on, in the hopes to help expand and grow this program throughout Saskatchewan.
That's great news. I see that Karen has her hand up. I'm just wondering if we can unmute Karen and Karen can ask her question.
Hi, thank you. Sorry about that. I was muted and unmuted. Sorry. Yeah, I really appreciate the work that you're doing. My question is actually kind of a continuation of what Christine asked. Indicated it was a demonstration product. I saw that it was kind of like on a 50% ratio for everything. And I think I'm more interested in seeing the longevity of it in the sense of actually the whole research project itself to see exactly where things aren't being met, or as well as with the improvement. I'm just wondering too, like, if you what's the hours that the workers in Angela's position work, and how many are right now in Saskatchewan at what locations? Because I believe I saw that there was at least 10 that were trained. So just some update on that, please, and thank you.
Yeah, thanks, Karen. Currently right now we have an Indigenous birth support worker working 1 per shift, so 1 every 24 hours we have someone on. We did do, initially there were 10 people, I believe, that did go through the training. Just with life and movement on, we don't have all of the same staff that we previously had. So we're looking to grow and expand our team as well. In Saskatoon, that is our goal, to keep and grow this program here and work with our colleagues in PA and Regina and into rural Saskatchewan as well.
Thanks. I think we have time.
Actually, Christine, if you don't mind, is there a timeline that you have on that for the movement outwards into the rural areas, especially northern Saskatchewan, where the large majority of babies for Indigenous people are being born?
Karen, I don't have an exact timeline on that piece right now. I'm working with my directors and my executive director on that piece and how that will work in Saskatchewan.
Thank you.
I think we have maybe time for one more question here. And is there anyone else who has a question, or else I have one question for Angela. And Angela, we have Trina. Trina, please go ahead.
Sorry, I'm not sure if you could hear me. It's a little windy, but my one question was of how could we pair up with First Nations and kind of, if it's not possible to expand into other hospitals, kind of remodel it with the help of many different First Nations so that it can be for on and off reserve people?
Another great question, Trina. I do believe that there's opportunities for growth and development that way. At this time, I don't have an answer for you on that, Trina, but that's something that I do see a lot of, especially the northern communities, needing and wanting some of this support. So I feel like there's definitely the room for the growth on that, but I don't have a concrete answer for you on that, Trina.
I see that there is some other questions that people would like to ask. I know that we need to move on to our next presenter, so I just ask everybody else to write the questions in the chat box, and we can forward them to you, and maybe you can answer them as well when you see them crop up there. But again, wonderful to have you with us and to share that, yeah, really interesting work. Our third presenter is Dr. Mcintosh, and he is the co-director of the Saskatchewan Population Health and Evaluation Unit and a professor of politics and international studies at the University of Regina. His research focuses on public and population health policy and population health interventions. And Dr. Mcintosh will be presenting on the results from a World Cafe event with Saskatchewan adults on mental health and COVID-19. So once again, just remind everybody to submit those questions, and I'll turn it over to you, Dr. Mcintosh.
Thank you very much, and thank you for the opportunity to present today. I want to begin and acknowledge that the University of Regina sits on Treaty 4 and Treaty 6 lands and in the traditional homeland of the Métis, and that we pay our respects to the First Nation and Métis ancestors and commit ourselves to building a more just relationship for all who share these lands today. I also want to acknowledge my co-authors in this project, Noel Novik, Elena DeCorbe, Nazima Hajarin, Bonnie Jeffrey, and Natalie Callio, all of whom have an affiliation with the Saskatchewan Population Health and Evaluation Research Unit that exists both at U of R and at U of S. I also want to acknowledge the funders for this work, the Saskatchewan Health Research Foundation, Mental Health Research Canada, and the Office of the Vice President Research at the University of Regina. What I want to report to and talk about today is really a smaller part of a much bigger project that is underway, and it's built around a partnership that's developed over the last number of months with Mental Health Research Canada and the Saskatchewan Health Research Foundation. MHRC has been since almost the very beginning of the COVID-19 pandemic, been doing a series of national surveys of Canadian adults to check in on the sort of mental health impacts of COVID amongst adults. With the support of SHRF and the Office of the Vice President Research at U of R, we got MHRC to add essentially oversamples on those surveys in the province of Saskatchewan that then allow us to pull out the Saskatchewan responses and have a robust enough sample in order to get a better sense of the specific impacts of COVID on adults across the province. This has resulted in a number of sort of initial publications, a couple of research briefs, and sets of infographics on the first two waves of data. These are both available on the SCPOR website. And this is ongoing work, and I'll say a bit more about that as there are going to be subsequent waves of data coming at us with Saskatchewan oversamples that we will begin to analyze, eventually giving us a sort of time series of the mental health impacts in the province. But we also wanted, and this is where this particular element comes in, we also wanted to build on just the sort of quantitative data contained in the surveys, and wanted to connect those survey findings with the lived experience of people in the province, and to really ask ourselves, what do the impacts we see mean for community mental health services in the province going forward. And so to that end, we convened a modified World Cafe event over 2 days in May of 2021 with roughly 30 participants. These included frontline service providers, clients, community mental health agencies, patient advocates, policy people from the Sask Health Authority and the Ministry of Health, and a few researchers. For those not familiar with the process, World Cafe is a methodology, a qualitative methodology that SCPOR has been using significantly over the last number of years. It's a strategy that helps generate dialogue and ideas from a wide array of citizens, stakeholders, and interested parties. It has an emphasis on strength-based learning and mutual creativity. It's built on a series of rotating facilitated table discussions on the specific questions of interest, and then plenary reporting back to the whole. The overall goal is to try to identify common themes, ideas, and issues raised, and then have those validated by the participants, as that is a reflection of what they said and how they approached the issues. I won't go into any detail. We had to modify the event because we held this as a virtual event because of COVID. And so we shortened it up and changed it, but worked it in a way that allowed us to do it over Zoom, which has some interesting challenges, but also, and you'll see in the report, some interesting advantages to doing it virtually. So to get into the heart of the matter, the surveys themselves found, and this is probably not surprising, reported increased levels of anxiety and depression amongst Saskatchewan adults, that there was increased substance use and significant significant trouble in accessing services, both for people who were accessing services prior to the pandemic and those who were trying to access mental health services as a result of the pandemic itself, and an inability to get the appropriate services when and where they were needed. We built the World Cafe around two questions for the table discussions. The first was really, do the survey results square with your own experience within the mental health system in the province, and then moving that forward into what needs to change in terms of how we may think about delivering community mental health in the future, and how do we reach the specific populations that the conversations identified that appear to be in greater need. As a general overview of what we found, there were four sort of key themes that resonated throughout the conversations during the day and a half, and then just a rather detailed discussion around the sort of challenges and opportunities that exist moving forward. And I'll go over each of these in a bit more detail. First and foremost, and probably not surprising, was that the system was simply unprepared for the pandemic. The scale of the pandemic was unforeseen, and the system did not adjust quickly or easily. For many of the participants, this highlighted the already poor referral and access linkages between the healthcare system and community located services, and exposed a lot of the gaps in access that many people knew about, but which many of the public may not have known or been aware of. All of this is exacerbated by the public health restrictions, the need to isolate, the working from home, etc. And it often left those seeking services feeling very frustrated and feeling ignored by the system. And so none of what was found in the surveys was really surprising, and it was very much reflected in the lived experience of the participants. And it really brought for them the need to change into even sharper focus. Secondly, and a great deal of time was spent on this, was that the existing inequalities in access to services were simply made worse. Whether these were geographic, a traditional sort of rural-urban divide in the ability to get services, a north-south divide in the province, a very clear racial divide. Indigenous peoples, racialized minorities, new immigrants were hit much harder and expressed much harder or much greater challenges in accessing appropriate services where they lived. A division around socioeconomic status, low-income individuals and the working poor in particular. It was also clear that there was a gender divide, that men and women experienced both the mental health stress and the pandemic itself in very different ways, and this was evident in the surveys and reiterated through the experience of the World Cafe participants. And it also was a health divide. In it mattered whether you were seeking or receiving services before the pandemic and were struggling to try to continue those services, or whether you were reaching out for services as a result of some of the impacts of the pandemic itself. All of this for the participants made the sort of the intersectionality of the social and economic determinants of health much more evident. And as people said repeatedly throughout the day and a half, COVID does discriminate. And it does discriminate along these barriers, and these barriers actually, and these divides reinforce the challenges in accessing mental health services in their communities. Thirdly, and this was particularly important in terms of the going forward, again, was there's a real challenge of getting reliable and trustworthy information about accessing mental health services. As one of the participants said, and echoed by many others, the service access was just simply clumsy. And as a result of that, people were getting discouraged in looking for help and abandoning the look for help. Efforts to reach out via social media worked for some, but certainly not for all. Age, technology, internet access, as we know, in rural and remote areas in the province can be a problem. There is sometimes a feeling of an over-reliance on, we can use Facebook, we can use Twitter, we can do all of these things, and not acknowledging the people who that leaves out. It also exposed the fact that there are still big data gaps in terms of where the services are in the province at the best of times, and this was only exacerbated as the services moved and shifted into different modes and modalities of delivery. If there was anything positive that came out of the discussions at the World Cafe, it was the hope that COVID had actually shone a very important light on mental health issues and the challenges of accessing mental health services, not just in the province of Saskatchewan, but more generally across the country. As somebody said in one of the groups, COVID was a kind of a generalized trauma, and it pushed mental health issues front and center, and it allowed people, even people who were not experiencing necessarily mental health challenges for which they would seek services, but it gave them a sense of what it would be like, because they themselves were also isolated and trying to do new things in new ways. And there was a hope that we could use this as an opportunity to sort of reduce the stigma of mental health. It was also acknowledged that there were some opportunities for community-based collaborations that had not happened before, that people were by circumstances sort of pushed into innovations, and that there were some really creative solutions found for the delivery of services for some people, and that there was also the growing use of sort of independent self-help options as well. When we move the discussion to sort of what does a post-COVID Saskatchewan look like in terms of mental health services, we begin to see a sort of a lot of thinking around a need to re-emphasize that need to break down service silos that exist not only inside the government, but between in terms of different government departments, health, social services, and the like, but also between the government, the health system, and the community-based organizations that are actually delivering services. Need to recognize the innovations that did occur during the pandemic and sustain and nurture those, and look for ways to transfer good practices. The words flexibility and innovation came up again and again as sort of key elements in any rethinking of how we would deliver mental health services going forward. And that using that flexibility and innovation to really confront the intersectionality of the economic and social factors that reinforce those unequal impacts of the pandemic. There is also a question about can we strike while the iron is hot? There was a feeling, and to put it in sort of political science terms that I sort of understand, that there was a window of opportunity for a real conversation about some policy and system change around mental health services. But windows of opportunity for change don't stay open forever. Right now, mental health is front and center in people's minds as a result of the pandemic, and we need to move quickly in order to do that. We need to create and retain an openness to the innovative models of service that did work for people, and think about how we can design services going forward that, and again, using that flexibility and innovation notions, that there would need to be different models of services for different people with different needs living in different places. The keys to this are mobilizing support across those sectors, and mobilizing resources to ensure success, because change will often require new resources. But as somebody also noted, mental health services has been one of the most under-resourced parts of the health system for many decades, and that requiring more resources is in fact necessary anyway for taking mental health seriously. Where our work is going forward, there are further waves of this data to come. We think the World Cafe has helped start a conversation amongst groups of people and amongst participants who wouldn't normally wind up in a conversation with each other. So as those waves of data come, we'll continue to add the research briefs and to develop and expand the sort of quantitative analysis that comes out of the data. But we also want to continue the sort of qualitative conversations that we've begun with this wide range of people. So we're beginning to think and lay plans probably in the new year for another World Cafe to try to keep the conversation moving and going forward. And there is the website there where you can find not only the research briefs and infographics, but the sort of full report on the World Cafe event that we held in May. And I'll leave it there.
Thank you so much, Dr. Mcintosh. Fascinating information there. And I don't know if there's any questions. I'd love to have at least a couple before we close here. You sort of answered my question right at the very end, because I thought, you know, given the fact that you talk about the system was unprepared, past tense, I was wondering if there'd be another World Cafe to see if the system did respond in any positive way, and if it is, you know, if we are really sharpening that focus, because I think one of the things is that we're, I guess, unfortunately still in the pandemic, and we're still in the midst of it. So there's probably more to learn as we move forward. And it's fascinating to think that, that we have the term generalized trauma, very interesting, and just to see what that looks like maybe in another 6 months or in another year.
And this is the thing, is that we have this nice we're going to have this nice time series of the quantitative data. And it will also allow us to look at Saskatchewan in comparison to the rest of the country, and look for the similarities and differences there. But then we're very much wanting to try to continue that conversation on about, you know, are we, even though we're still in the midst of it, we've been doing this for 18 months, 20 months, 24 months. Are we getting better at delivering these kinds of services? Absolutely. Right? And do we have more examples of more innovations and more examples of the ability to go, you know, that worked over there, and maybe we can try that there. And so that's why I really want to do this again, in order to sort of both continue that conversation, but also to see how the system is evolving over the course of a very long period of time.
Oh, I think that would be fascinating, and not to you know, to suggest that there's any other way to do it, but it'd be interesting to see what the same people say in 5 years or in 10 years, right? Yeah. You know, fascinating stuff. Is there any other questions? I think we maybe one more, and then I know that our time is coming to an end here. Any other questions? On that note, I think, yeah, we've come to 12:15, and I think that's when we were supposed to sort of shut it down. And I just would like to thank all the presenters for sharing and inspiring us this morning. There's definitely reason to celebrate the health research being done in Saskatchewan. This was evidence of it in this short hour that we had together. And thank you, Michaela. Thank you, Mamata, and thank you, Tom. Again, very appreciated that you were willing to share with us today. On a housekeeping note, next on our program is a brief 15-minute break, and then that's followed by a patient partner event. So I encourage you to go grab a drink or take a stretch break, and we'll see you at the patient partner session at 12:30. Again, don't forget, you need to go to the sessions in your menu and select the session you'd like to attend. And again, you'll probably see on your screen that there is a short survey that's just popped up. So thank you everyone again for joining us, and have a good break, and we'll see you at the patient partner event at 12:30. Thanks a million. Bye-bye.